All right, so it's 8:02. We have a good number of attendees that have joined our session. And with this, we'll kick off our live webinar with Dr. Dana Rice and Dr. Thomas Rechtschaffen. We'd like to start by welcoming all of our participants today on behalf of UTIVA and the myUTI team. We're excited about today's live session as we have amongst us two urologists for tonight, and who will be discussing some very practical approaches from their own practice in some very common UTI cases. Today's event is actually brought to you in partnership by two companies that are in the urology space, two young and upcoming companies, as we like to say, UTIVA and myUTI. So UTIVA is a company focused on UTI prevention. We have a wide range of supplements that we can always share later. My name is Faraz Numani, and I'm the co-founder of UTIVA, and I'll be one of your moderators for the evening. Along with me is Lindsay, who's the co-founder of myUTI, who will also be moderating the advanced diagnostics section of the talk today. We'd both like to thank our esteemed guests, but also everyone that's joined the call today. So today's talk will be approximately 35 minutes between the two speakers, and then we'll open it up for question and answer, and we're hoping we can get at least 20 minutes of Q&A. Towards the end of today's talk will be a live raffle that some of you might be aware of. Everyone who's registered for the talk has been automatically entered in, and we'll do that towards the last minute of tonight's talk. If you have any questions for the speaker, you do not need to wait for the talks to finish. Just pop in your questions in the Q&A section right at the bottom of the Zoom window. So this way we have your questions ahead of time and we can start organizing them and get to them as soon as they're done. So with this, I'm going to introduce our first speaker for tonight, Dr. Dana Rice, and she'll be reviewing the first case for the evening. So Dr. Dana Rice is a board certified urologist practicing full-time at the Inova Fairfax Hospital in the Washington, D.C. area. Dr. Rice completed her medical studies and her postgraduate residency at George Washington University. She's co-authored a chapter in urinary tract infections and is the creator of the UTI Tracker app. Dr. Rice was named a top doctor in the Washingtonian magazine and Northern Virginia magazine. She lived in Virginia and maintains a very busy surgical cancer practice, as well as being a wife and a mother of two young daughters. So without any further delay, please welcome Dr. Dana Rice.
Thanks so much, Faraz. So when we first talked about doing these presentations, we were looking for something kind of quick and dirty to help explain kind of common themes in my practice and what people can kind of look for and how we can work for antibiotic stewardship. Creating the UTI Tracker app, my biggest thing is education. So I really wanted to make sure that we're getting the word out there on how to look at patients from a different lens, not just antibiotics. So I picked this first case because it's a suprapubic tube, and most people are afraid of suprapubic tubes, I have found, as I've gone through a urology residency and now practice. And basically what I found is that if you handle these patients and you work with them and you educate them very nicely, you can get away without giving them very many antibiotics, which is a goal. So this case is a case study. It's a 54-year-old gentleman who I know very well. He moved to the DC area after he had already had a suprapubic tube in place. After his neuropathic injury, he basically became incontinent of urine and initially had multiple infections. Ultimately, he moved on to a very complicated urological course where he was catheterizing himself pretty regularly and then ended up with some stricture disease. So his urologist had put in a suprapubic tube, and over the last year in which he moved to DC and did not have a urologist, he had been hospitalized multiple times, and this is where I had met him. So I'm going to walk through how I managed him after I met him. And this is just a quick picture for those in the audience who may not know. A suprapubic tube is a fancy word for a catheter that goes through the belly and into the bladder instead of into the urethra. This patient in particular, other than his accident, was extremely healthy. He has a little bit of high blood pressure. Due to his accident, he had to have spinal fusion. He's had cystoscopies before. As I said, he's had strictures. And then this gentleman in particular was very adamant that he wanted to be completely independent. And like many patients who have paraplegias, it's hard to maintain a good bowel regimen without skin breakdown or ulceration. So he chose to have an encolostomy, which essentially is a bag on his stomach so he could manage his own stool, and he did not have to be in a diaper. He's taken multiple antibiotics and most recently had IV meropenem. And when he came to me, I said, hey, bear with me. Let's see what's going on. Let's see what you're doing with your suprapubic tube regimen, and let's see how we can kind of fix you. So as I said, when I was introducing, he had an SP tube in place for 2 years. He'd been hospitalized multiple times. And he also noted, as I asked more questions, that recently he was having more and more urinary incontinence, which had been relatively new for him since he's had his suprapubic tube in place. When he was catheterizing himself, he did not have incontinence very often. He also, in the urology world, we never forget to ask about penises. So his erections were working fine with something called trimix. I went through all his charts and what he brought with him. And I noticed that when he was doing clean intermittent catheterization, he would have E. coli and enterococcus, which are 2 common bacteria that are found in bowel and bladder. And then with his suprapubic tube in place, he had staph, which is a common skin infection, as well as the E. coli. But the E. coli was really a super common theme for this patient. And when he would get septic, he would have E. coli in his blood, hence the sepsis. And that was a problem. One thing and pattern that I noticed in particular is that even though he had a lot of infections when he was doing intermittent catheterization, he never actually was hospitalized with sepsis. So it wasn't in his bloodstream. So we had to figure out what was going on here. He often was given multiple antibiotics for long courses. He had infectious disease on board. And then somewhere along the line, they gave him a low dose macrobid or nitrofurantoin to try to keep away the infections. But obviously hospitalized 4 years with sepsis, we're not doing such a good job. We also tried, or they tried, to increase his suprapubic tube changes to every 3 weeks, which is possible if the tube is the source of the infection, but it clearly wasn't working either. Again, every quarter is way too many. This is a picture down in the corner on the left-hand side of the screen of what a bladder that's not super functional. Those are called trabeculations. And basically what I tell people is think of an overcharged balloon. If you have a thick-walled, thick balloon, it's never gonna expand and contract the way you want it to. So this gentleman has a history of a poorly working bladder. He had strictures, but that was 2 years ago. Nobody had looked into his bladder since he had his suprapubic tube put in place. He had a CT scan, but again, it was a year ago and he didn't have any stones or problems then. But on his ultrasound, when he came into our hospital, it all looked normal, no stones, but nobody's looking at his upper tracts to see what happens with the urination, because if your bladder does not open well, sometimes you can have urine head back to your kidneys. And if you have a suprapubic tube in place, it's constantly draining. If it gets clogged, these are the type of patients that sometimes can shoot urine to their kidneys, and that's how you get infected. So this is something that I had to really sort of work with him and talk to him about. When I go into all these details for patients, you've got to really just sort of dig in with them and figure out, why are you leaking? What's going on with your bowels? Tell me more about your infections, and let's break it all down. Incontinence for this patient in particular is something that when he would move or when he would transfer, he would have leakage. So it wouldn't be from his suprapubic tube, which was in his abdomen. He would actually leak urine from his penis, which you can imagine, if you have a tube coming out of your belly to drain your urine, you really don't want it to be coming out other places too, right? That's lifestyle prohibitive. He noticed that whenever he got infections, that the leakage would get worse. And that when he was doing intermittent catheterization, he didn't have as many infections where he would have leakage. He would be able to transfer. In particular, and of note, he does not ever cap his suprapubic tube. So his bladder currently drains all the time. Urine from the kidneys to the bladder, bladder to the bag. It never has any stretch or release time. It's just constantly emptying. And he's also not on any medication for bladder spasms, which is empty, empty, empty. So he has nothing to relax his bladder.
Hey, Dana, just 1 second. I
Yep.
think we got a note that said, show the slides as the main screen is not the speaker. Do you want to just stop sharing and just share it again? And sometimes that fixes that issue.
Okay, stop sharing and then reshare.
Yeah. All right, and try it again. Okay. I know I can see it on my end. Can someone comment as the attendee if they can see the slides?
I can see it.
Should I get rid of this maybe? Because
No, it's good. Then it's good. I think we just got a couple of messages that said it's good.
okay, keep
Keep
going.
going.
Okay. So we just talked about his incontinence. The bowels are actually fairly straightforward for this patient at this point in time. He was having stool leakage, which also goes along with infections, but he ended up getting a colostomy so he could manage his bowels. And the reason for that was he was getting a fecal impaction. So that could have been the reason for some of his infections initially. And he also had some ulceration. So the long and the short of it is he needed some bowel management, but that was long before he got to me. This is sort of the take home for me is his infection history. So when he was catheterizing himself, he would be treated very regularly, almost monthly, for infections because when he would get his urine tested, it would either be cloudy or foul smelling. But when you talk to the patient, he really didn't have that many symptoms. So he was getting a whole lot of antibiotics because everyone was worried about infection, not necessarily because he was getting infections. However, what ended up happening is the strictures ended up forming and he ended up not being able to pass the catheter in and out. And that's when they decided to put the suprapubic tube in. So they put the suprapubic tube in, which should, in theory, be a much easier way to manage your bladder because you don't have to pass a catheter in and out. But the problem is now the patient was starting to get blood cultures positive and really bad infections requiring hospitalization. And he also had worsening incontinence. So something else is going on, right? Something's weird with his bladder. What it turns out to be, and as we kind of look at it, you can see down here, a stricture is just a very narrowing. So you've got your penis, and then you've got your prostate and bladder. And this area demonstrates how it's a real narrowing there. So he's not able to pass a catheter in and out to drain. And when you can't do that, right, you can get more and more infections. The suprapubic tube, 14 French, is a very small tube. So for people who aren't familiar with the sizes of catheters, smaller numbers, smaller lumens. That means they don't drain as well. So he was having a bladder that really wasn't draining well through a small tube, and he also could not pass anything in and out. So I sat down with him and I said, well, what do you want to do and where do you want to go with this? Because the problem is that I think that your bladder has been drained for 2 years. So your bladder has been completely empty for 2 years, which means you do not have any capacity to hold urine. If you do not have capacity to hold urine, you are not flushing out any organisms that can pool or irritate around your bladder. What can happen is your bladder, if it does get any kind of urine backing up, it can be spasms back up to your kidneys, and that's how you can get kidney infections or urosepsis, which is probably what his source was. So I sat down and I said, how do you feel about upsizing your catheter? Going from a smaller lumen to a bigger lumen helps things drain better and faster. How about we take a look into your bladder to see what's going on in there? And how about we do just a physical exam to see if I can see anything that looks like any epididymitis or testicular infection, things like that. And he's on board. He wants everything done so that he can get off these antibiotics. He has normal looking penis, testicles, ostomy look good. Everything about him looks fantastic. So you have normal anatomy. You're doing okay. I can get into your bladder when we upsize you. So series over time, I slowly over the next month upsized his catheter to a 20 French, and I looked in his bladder. His bladder had all those trabeculations. And I said, you probably have pockets of urine that are not draining because you're not filling and not flushing the bacteria out. So what we need to do is we need to start flushing your bladder, and we need to give you some UTI prevention. For me and with my patients, I really like the D-mannose for people who have E. coli infections. I find that if you are strictly an E. coli infection person, D-mannose at a treatment dose of 2,000 milligrams or at a maintenance dose of 1,000 milligrams really seems to work well. Okay. Utiva has products that have D-mannose in quantity. And then the other product that they have is a 36 milligrams Pax as an active ingredient. And that is really good for the enterococcus. If you remember that this guy has an enterococcus infection, the AUA guidelines use the 36 milligrams Pax for all UTI prevention. I use it a lot for enterococcus. I think it's fantastic. So I told this gentleman, let's get you on some supplements. Okay. Let's see if we can flush your bladder a little bit, and let's see if we can keep you without getting infections. He said, sure, no problem, doc. We'll try this. What do you suggest about flushing my bladder? And I said, well, there's two different ways we can do it. We can put antibiotics in there, cap the tube, and then drain it out. Or we can try to see if you can naturally start capping your catheter and see how we go, see if you can do it naturally. So what he did do is he started capping his catheter. And at first, if he capped even for 20 minutes, 30 minutes, he would leak from down below. But slowly he began working up. And then I also gave him another anticholinergic, which he had taken in the past to try to help with the bladder spasms. So we've got him doing multiple ways of preventing UTIs and also trying to get his bladder flushed out. He came to see me about 3 months later. His suprapubic tube is now in, it's now draining. His bladder looks like crap. So we've got to keep fixing that. But once your bladder function is gone, lots of times you don't get that back. So we have to make sure that we're doing the best we can for prevention. I was not able to scope antegrade. So from his belly down through his penis, I was not able to scope because his strictures were so bad. But the good thing is that he wasn't really getting infections at this point. He was able to drain his catheter better, and he's able to cap his catheter for 2 to 3 hours at a time. So he's able to fill his bladder and then flush things out. His getting bothered with his side effects from medication, but he was still doing better than before. So he stopped his medication, and he still religiously was taking his supplements, which for a patient who 4 times a year was going to the hospital with urosepsis has now gone 3 months without even having an antibiotic need for a urinary tract infection. That's a really big lifestyle improvement. We saw him after 6 months, and he's able to cap now because his bladder has capacity. So he's able to cap his catheter. He can go to work and uncap and use a urinal like in a regular bathroom stall, and doesn't have to wear a bag. He doesn't have to have leakage on transfers. Obviously, if he keeps his catheter capped too long and then tries to strain, he'll have a problem. But lifestyle-wise, he doesn't need a bag very often. He also hasn't had any infections. And we can also stretch out the timing of his suprapubic tube change to 4 to 6 weeks. So this is someone who is religiously taking his supplements. He's flushing, he's working on bladder management and behavioral changes, and he's doing exponentially well. And then finally, a year later, he's managing his catheter on his own. He's changing it. He's not leaking. He knows what to look for. He hasn't been hospitalized in a year. He's still taking his supplements, and he says, hey, doc, am I on this for life, or what do I need to do? And I review with him, listen, there's no side effects. There's no downfalls for taking these supplements. If you want to try to wean off and see what happens, you can, or you can say, what's, good for the goose, and stay on them. And this gentleman has chosen to stay on his supplements. And a year later, for antibiotic stewardship, he has not needed any antibiotics, and he has not been hospitalized, and he is completely independent of his own urine at this point. And the better part of this now is that we've had about 6 or 7 mid-level providers and other doctors who have been able to learn that, suprapubic tubes are not the enemy for patients, and they're not generally the cause of the UTI. It's the pathophysiology behind what got you the suprapubic tube in the first place that gets you into this repeated UTI cycle. So this was a fairly common case that we see where people misunderstand what's actually happening with the bladder, and they're treating for colonization as opposed to actual true UTIs and or sepsis infections that could have been prevented if we fix the capacity of the bladder in the first place. We're doing the 2 presentations first, right, for us?
Yeah, that's right. Then I'll do a quick time check with you.
Yep.
We are running quite over
Oh,
on
shoot.
your side.
Okay.
So you could wrap up the next case, if you don't mind, in like 5 minutes.
Yep.
That'll be perfect. Yeah.
Okay, no problem.
Okay.
So this is a quick case. Can everybody see it?
Yes.
Okay. This is a quick case that I get very commonly, and it's the bane of my existence. This is a case of a 20-year-old or 20-something who comes and tells me, I've had interstitial cystitis for 10 years. I have pains. Everybody's done everything. I take macrobid when I feel like I have pain. This person in particular had gabapentin as well for her pain. And she's just coming to me because she was from out of the DC area. She has no medical history to speak of. She did have a cystoscopy, which got her diagnosis. She takes macrobid after sex or with pain. She takes proteum if she needs it and gabapentin for pain. She does not have any history of sexual abuse. She does mention on the side that she has pain with sex when she has these flares and when she doesn't have flares, and she takes oral birth control, no pregnancy. I went through her medical records. Sure enough, she had some glomerulations with hydrodistension. This is a very common thing that people will say for interstitial cystitis. I personally think that you need biopsy positive for interstitial cystitis, and you need to rule everything else out first. But I don't mention that at the first visit generally because it makes people think that I'm blaming their other doctors. So we kind of went into this with, okay, let's see what's going on. We went through her UTI history. She said that she gets UTIs very regularly. But when you look at her actual cultures, only 3 of her cultures were positive for infection. She had 7 negative cultures. And as suspected, the amitriptyline, which a lot of people used to use for interstitial cystitis, caused side effects and did not help her flares. So she's someone who was diagnosed with interstitial cystitis, but I wasn't really convinced that we had gotten to the bottom of her picture. So the biggest thing for me is you really need to talk to these patients and find out real details about triggers. Got to go through bowel, you got to go through trauma, and then you have to find out what they're worried about. Have they tried anything? Breaking it down really specifically, ultimately it came down to the patient had 2 types of different episodes. She had one episode that was gotta go, gotta pee, dysuria, kind of common, typical urinary tract infections, lower tract symptoms. They lasted 2 or 3 days. She self-treated herself with macrobid. As soon as the pain went away, she stopped taking it. She never tracked it. She never knew what was going on or what brought it on. Her other big complaint was that a few times a year, she would have horrible pain that caused her to use the pain medication, specifically gabapentin. She would also start the macrobid at that time and sometimes take it for weeks or the whole time of the flare. She never really knew what caused it, but she would miss work as well as activities because the pain would be so bad. So she really had 2 separate things going on. I asked about her bowels, which in this case is normal, but you really got to pay attention. Constipation can really contribute here. Sexual history, lots and lots of times you'll have trauma, rape, or unwanted forced sexual encounters. And that can lead to some pelvic pain and feelings of interstitial cystitis. This patient in particular didn't have pain or difficulty for the first few years that she was having sex. It came on a little bit later. She had no history of trauma. And when I asked her about injuries, she was a competitive gymnast with a hip injury. But other than that, nothing really take home to report. She was very anxious and did read online a lot about cranberry juices, front to back, urinating after sex, and really focused on how she changed her lifestyle for these type of things, some of which are myths and some of which are not, which I can answer in the after visit or after wrap up. I did a full exam on her, which I think is crucial. We always get urine analysis and cultures to make sure that there's no ureaplasma, mycoplasma, which is actually very common in patients who are treated for interstitial cystitis. We checked to make sure she had a post-void residual, that she was emptying okay. She had normal anatomy, and then not surprisingly, she had a very significantly tender exam on her left anterior vaginal wall. So she was having pelvic pain to actual palpation, which is fairly common in patients who are diagnosed with interstitial cystitis. But sometimes we don't catch that because a lot of physicians don't always do a vaginal exam when they're working up interstitial cystitis. So I sat down with her and I said, listen, Rome wasn't built in a day. You've had this diagnosis for 10 years, but if you bear with me and you work with me and we can figure out what's going on and what's causing these flares, then hopefully we can figure out how to prevent them. So I gave her, the app. I created this app because I was seeing so many patients that had these problems. So the tracker app, the UTI tracker app, will track your symptoms, your bowel movements, your periods, your sex, when you have pain. It's a really detailed program. I also said, listen, you have point tenderness and you have a history of a gymnastics injury and weirder things have happened. Go see a pelvic floor physical therapist. We talked about safe sexual practices, not touching holes, all kinds of things that could prevent UTIs. And then I said, get yourself on some supplements. You do have E. coli infection, so Utiva and other supplements for probiotics for constipation, and then Utiva for the PAX and the D-mannose products are going to give you no side effects and can only help you. So let's start. And I know you want to self-start your macrobid, but please don't do that because I want to see if you have true infection. So walk into my office and get a culture anytime you have symptoms. Sure enough, after my first exam, her urea plasma came back positive. Like I said, it's more common than you expect. Her partner was tested and they were negative. She was treated with doxycycline and she did go to pelvic floor physical therapy and had trigger point sensitivity and was given 12 weeks of pelvic floor physical therapy. I saw her after about 6 weeks, 3 months, somewhere in there. This little dodgy slide, I can't remember exactly, but either way, on quick follow-up, she had one UTI and it was an E. coli UTI. We had to treat her with 3 days of Bactrim, but it was not a drug-resistant urinary tract infection. She's still taking her supplements. She was fairly frustrated, but I said, hey, work with me. Let's figure out your triggers. We went through her tracker app and we noticed that she had really bad diarrhea right prior to her infection. So we said, okay, listen, UTIs happen, diarrhea happens. Let's keep, stay the course. Let's see what happens. Her physical therapy had been going on for multiple sessions. She was now no longer having pain with sex. And at least for these 3 months, she had not had one of her major flares that required the gabapentin. So her suprapubic pain was getting better. I saw her back 12 months because she didn't have any problems. She had one UTI, which she did come in for a urine culture, and I treated her with a 3-day course of Bactrim again. She said it was completely related to when she was her anniversary. She had had a lot of sex. She was not taking her supplements at the time. She had stopped taking them because she had gone a long time without having infections. She was not having any suprapubic flares since her pelvic floor physical therapy. So we reviewed, starting supplements at a higher dose of 2,000 milligrams of D-mannose, as well as the 36 milligram PAX. Anytime that you're going to have a trigger weekend, honeymoons, lots of sex, drinking, all those things that 20-year-olds tend to do. And then we went through all behavioral changes and physical therapy exercises. And this is someone who essentially went from having a diagnosis of interstitial cystitis from her late teens to her early 20s, when really she had just frequent UTIs likely related to intercourse and pelvic floor dysfunction. And it really emphasizes how much you need to speak to your patients and how much you need to set expectations about what may or may not be a pelvic pain syndrome versus interstitial cystitis versus anatomical causes. And all of this, helps reduce your antibiotic use and then your long-term management of your bladder.
Thanks, Dr. Rice. That was a really good detailed review of both those cases. For those who have questions, don't wait till the very end. You can start posting your questions in the question and answer section, and then we will get to it right after the next part of the talk. So with this, I'm going to hand it over to Lindsay, who's going to introduce Dr. Rechtschaffen and take over the next part of the talk.
Thank you. I am thrilled to introduce Dr. Thomas Rechtschaffen, a board certified urologist with Advanced Urology Centers of New York, who has 20 years experience focusing on women's urology problems, including UTIs, incontinence, voiding dysfunction, and interstitial cystitis. He is passionate about advancing technology in diagnosis and treatment for the benefit of his patients, and his group routinely uses advanced UTI testing for patients who struggle with recurrent UTIs and pelvic pain. Dr. Rechtschaffen, thank you so much for joining us.
Thank you, Lindsay. It's a privilege to speak to all of you. I understand the audience is probably partially urologists and partially primary care. So for the urologist, I apologize if some things that I say are a little more basic. I want to make sure everyone kind of knows where we're coming from. I think Dr. Rice did an excellent presentation. I have that suprapubic patient as well. So I know it very well. I will say this. So when I chose to practice in one of the most densely urology communities in the country. And so, you know, the patients you get when you come in are all the patients no one else wants. And there were no urologists treating women in the area, surprisingly. And 20 years later, there's only one other urologist treating women. So, you know, it was both out of necessity and really just caring about people who were frustrated. I think I use the term interstitial cystitis a little more loosely. And I'll tell you why. I think the first problem these patients have is that no one's really listened to them. And they've been tested up the wazoo. Everything is, quote, normal. They haven't gotten better. They've usually been treated with antibiotics over and over and over again. And they're frustrated. And then they're told at the end, so as the urologist gets frustrated with them or they get frustrated with the urologist, there's always some bad interaction. They walk away after some remark that's insulting. And I hear about them when they come to see me. So I think the first thing is, if they think they have IC, I listen to them and say, okay, you have IC, let's talk about it. But so IC was always called a diagnosis of exclusion. And because all these women are coming to me not being treated, I said, no, let me start with IC and exclude it first and then move on to what we're doing. But I think, you know, I've never kept it sort of ideological. So in the patient you brought up, I think the patient, you know, very well could have a component of IC or pelvic pain or whatever bucket diagnosis you want to make. Looks to me like she was being mismanaged with her IC on macrobid and gabapentin. And exactly what you did is what I do with these patients. It's more of a holistic approach. Pelvic floor therapy, elimination diets, supplements, absolutely. And anticipating, you know, sort of flares that might come up, triggers that might flare them. So in a way, even though it may not be classic IC, what you found, it's kind of the way we think we should manage these patients anyway. I think the holistic approach is very important, including stress management. Yoga is great, but I told them do the yoga positions that are meant for pregnant women, because anything that really attacks the core your core is going to trigger more pelvic pain. We don't have a lot of good pelvic therapists in our area, but when I'm able to get someone to them, it's definitely a positive thing. So I'll just, you know, say that. And then we have a slide, Lindsay?
Yeah, we do. And I was going to ask you, I mean, I think obviously that sentiment being echoed across these presentations around the need to really dig in with these patients, to listen to them so that they feel heard, but that also so you as clinicians can gather, you know, more and appropriate information, you know, to make a better diagnostic decision for them.
Right. So these patients often come in the same way. They've been on 7 rounds of antibiotics, 7 doctors. They aren't better. They get better after about 5 days on antibiotics. If you really have a UTI, you should get better within the first couple of doses. And we give 5 to 7 days to make sure it doesn't come back. But if the patient's not getting better after the first dose, it's probably not a UTI. And IC flares probably last 4 to 5 days for these patients anyway. So they're thinking that after 5 days, they're better, and that's because it was a UTI. In general, for, again, the primary care doctor in a rural area even, a kidney bladder ultrasound is cheap. It's easy to get. You know, it's something that can really help you with a patient who is not responding to therapy, because there are some patients who may have retention. They're not emptying their bladder very well. They may have a stone that's not causing pain, but might be seeding infections. So I think getting a renal blood ultrasound is a good place to start, you know, as a primary care physician. Again, cheap, easy to get, almost anywhere you can get it. It might give you some more information. A dirty urinalysis is not diagnostic. So how many times do they go to urgent care? They say, oh, they told me I had a UTI, they gave me antibiotics. I'm like, did they call you back 2 days later with a culture? No. Well, you know, that's not really a UTI. So a UTI classically is always meant 100,000 bacteria, and usually one that we know about, like an E. coli, Enterococcus, Klebsiella, something we know that causes UTIs, and they give you a list of drugs that it's sensitive to. Well, that's what a UTI is. We'll talk a bit more about what's not a UTI, but of course, if you get a 10,000 mixed flora, possible contamination, which we've all seen a million times, Does that mean she had a UTI or not? It used to mean not, but actually things are changing. But if you have a patient who is in pain, by the time the culture comes back and you call her back 3 days later, she's better because her flare went away anyway. Well, it wasn't mean because she had a UTI. So just be careful and always get a culture if you can. Another soapbox item for me. The FDA has put out several communiques warning against the use of fluoroquinolones, Cipro and levofloxacin. They've been overused. We have a lot of resistance to them. So we went through a phase of all kinds of prostate biopsy sepsis because they gave everyone a dose of Cipro and they were all resistant to Cipro, but sensitive to Bactrim. So, and if you give Cipro and Levaquin to enough people, there are some pretty terrible side effects that can happen in small percentages, but over large populations, they tend to happen a lot. Please, please don't give Cipro or levofloxacin unless it's the only oral drug it's sensitive to. And this goes, the ER hasn't figured this out either. Every ER patient comes to me on Cipro. So please stop Cipro. I like cefuroxime, Ceftin. I love Bactrim if there are no allergies. Cipro and Levaquin should be avoided unless it's the only drug available. Sometimes their symptoms can outlast the infection. So you've treated the infection, but they're still feeling some burning. Well, patients who may have recurrent infections or again, just chronic pelvic pain may have a longer symptom course than the infection. So before you give them another round of something, say, well, let's repeat the culture to see if it's still there. Things like Pyridium, Urabel, azos over the counter. Treat the symptom in these patients because it may be that the infection is gone, they're just not quite better yet. Doesn't mean there's still an infection. And overall, I think elimination diets, my patients who've done the best have done elimination diets. And this is not necessarily for UTI specifically, but for all kinds of pelvic pain, whether it's cystitis, bacterial, non-bacterial. There's a lot of stuff in our food that's not good for us, a lot of preservatives. There are lots of acid in foods you wouldn't necessarily realize. So I put all my patients on elimination diets who've had chronic pain for years. The ones who can do it have done the best and often can avoid medications altogether. For patients who come in, see me and say, I've had 7 UTIs this year, unless they're horribly immunocompromised, which is not usually the case, and they're younger, it may not be UTIs. So I believe more in IC, and I think I use it a little more broadly than it might be defined officially, but pelvic pain syndrome. It may not be a patient who needs Elmeron, but it may be a patient who can benefit from Urabel once in a while, again, from stress management, watching their diet, and supplements are excellent. You want to keep the urine not irritant. The other thing that we've learned recently is urine is not sterile. And this became a shock. In fact, when they started doing the Human Genome Project and looking at the human microbiomes, they didn't include urine in the study because everyone felt, oh, urine's sterile, why even bother study it? Well, guess what? It's not. There is a microbiome and there's a healthy microbiome. And the healthy microbiome is different in patients who we'll say are normal without symptoms versus patients who have incontinence or stones or cystitis or recurrent UTIs, et cetera. We can't necessarily pinpoint what's different yet, but it's different. So respecting the microbiome in a patient is important because if we start giving them antibiotics empirically on a whim, just in case, or because they asked for it, we may be damaging that microbiome. And in patients who are older, who we know sometimes colonize their bladder or have thought in the past to be colonizations of their bladder, give them antibiotics might make them worse. So unless you're giving targeted antibiotics and not just general antibiotics. So the microbiome, and we've been able to find the microbiome because we now have these advanced diagnostic techniques. Okay, some people, there's PCR, there's ribosomes, there's shotgun genomics. And this gives us the ability in parallel to culture out everything. So what's wrong with the culture? Problem with culture, I mean, Louis Pasteur used cultures in the 1850s. So we kind of need to advance the technology. It's 2021. Some things won't culture out. Some things won't last from your office to the lab to be cultured out. Some bacteria are too expensive to culture out, and they're not done. With these new technologies, we get a whole list of things that are going on in the person's bladder. So one of my favorite patients, she came in, and again, she was, when I first met her, I said she was an IC patient. And obviously, as the technology has improved, I've changed my idea. But she came in on antibiotics every summer. Every summer, she got a UTI. I said, really? Well, show me the cultures. And the cultures were negative. What do you do in the summer? Well, I go to the country club, and I drink iced tea with my friends all summer. I'm like, well, iced tea is a huge irritant for the bladder lining. I said, why don't we stop the iced tea? I gave her amitriptyline at the time and Urabel for flares, and she got better. Now, I saw it as a win at the time because I got her off all these antibiotics. Well, then she came in last year, and I was able to do an NGS, a shotgun genomics test on her urine. And her urine culture came back, 10,000 colonies, mixed flora, probably contaminated, which all of us, up until probably last year would have said, oh, that's negative. Maybe we would have repeated it, or in the urologist's office, we might have done a straight cath. Well, I did an NGS on her, and guess what? I got a whole bunch of stuff back, stuff I hadn't even heard of, but stuff that was definitely pathological, and they were all sensitive to Flagyl, which I never would have given her otherwise. Her culture was negative. Her NGS was positive for 3 bugs in high numbers, all sensitive to Flagyl. And the happy end of the story is I gave her a week of Flagyl. She didn't drink for a week or 2, and she's better. She's off the amitriptyline. She can drink her iced tea. So that really changed my management. And that's not the only story that I have. I'll spare you the rest. But more and more often, I'm getting these things back, whether it's mycoplasma, ureaplasma, or a whole bunch of things I can't even pronounce that are sensitive typically to Clinda and to Flagyl, stuff I normally wouldn't give a patient to treat a UTI. So I think this new technology is very exciting. I think that if we can maintain a healthier microbiome for these patients, a la using supplements, probiotics, D-mannose, certainly, that's a new avenue for treatment, and a very low risk avenue for treatment. Antibiotics can be very dangerous and can cause side effects. And like I said, if they hurt the microbiome, they can put them at risk for more infections in the future. So I think that looking at these things a little bit differently and being more open to what's out there is important. Now, I wouldn't do advanced testing on every patient that walked in the door, obviously. There are very specific groups of patients that I will do it on, and only those patients. The chronic prostatitis patient, the person who comes in with diagnosis of IC, the patient who has been treated for her UTI, it's negative now, but she still feels ill. So that's a good advanced diagnostic patient. And these tests are more available than you think. We're lucky because in my group, we do it in our own lab. So we're able to get a result back pretty quickly. I know the people running the test, and we're able to get the patients a better treatment. But so I think there's a new age coming on in treating these infections or cystitis patients with more information that's out there.
Thank you so much for sharing that. I know I've just seen the Q&A blow up over here. So Faraz, I don't know if you want to enter into our question and answer session. I think we have quite a few questions. We're going to try to get to them all.
Yeah, no, thanks, Lindsay. And thanks, Dr. Rechtschaffen, for a good discussion on the advanced diagnostics. That was great. So we have a number of questions that are coming in, and I want to remind everyone that if you do have your question, please enter it in chat, put it in the chat box, the Q&A section. Let me start off with Dr. Rice. There were a few questions that came in for her. So here's the first one we have. So Dr. Rice, do you use prophylaxis antibiotics to prevent UTI for patients with recurrent UTIs? Some say that it does not really work to prevent. It only removes an antibiotic option to treat, as you will get resistance to the antibiotic.
Yeah, so that's sort of a multi-part question and something that I see a lot. So I do see a lot of patients who are coming in and they're given either macrobid or low-dose Bactrim as postcoital or preventative. I don't pigeonhole anybody anyway. So for instance, I have patients who I've tried everything, right? We've done a million different things. We've tried different cultures, and sometimes you just can't get rid of it. So for instance, actually relatively recently, I had someone who has Alzheimer's and doesn't empty her bladder and has had recurrent infections no matter what we do. And I just had a long discussion with the daughter and the family. And I said, you don't want another episode of urosepsis, so let's try a low dose prophylaxis. So she's on a 90-day prophylactic course, knowing the risks and benefits. Is it my ideal treatment? Would I prefer to get someone on supplements and off antibiotics? Yes, but there is a time and a place for antibiotic prophylaxis if you can't figure it out, or if the risk for the patient is recurrent urosepsis evaluations. But I do think that that's a little bit of a higher level workup. And I would recommend that if you're thinking about doing antibiotic prophylaxis, that should probably be someone who sees a urologist to make those decisions.
Okay. Okay, great. The next question, actually this question could go to both of you, Dr. Rice and Dr. Rechtschaffen. It's around using pyridium, phenazopyridine, for dysuria symptoms with UTIs or interstitial cystitis. Do you suggest NSAIDs for dysuria?
I can say, so for my patients, as long as you have normal kidney function, I don't mind if people take ibuprofen. I don't want you taking it long term, all the time. But azo or pyridium, right? Those are also short-term drugs. So what I usually tell my patients is I want a urine culture as much as possible. And it sounds like, oh my God, Dr. Rechtschaffen, I'm going to butcher your name. I'm so sorry, sir. Sort of has the same theory there, is that cultures are definitely the way to go. And pyridium or azo is a good way to buy yourself a little bit of time. So someone who calls on Thursday and is miserable and is having dysuria, if you have a Urabel or a pyridium on board and a little bit of ibuprofen, you can get to the point where you can at least see if there's something growing out in the culture, instead of having to just give antibiotics and call back if the culture is negative, because that's often a lot of times what we have to do because patients are so uncomfortable. So in my chronic or recurrent UTI patients, they're pretty well aware that, you know, if you've had a negative culture before with symptoms, then I'm not going to give you antibiotics until I see that culture. So NSAIDs and pyridium are good. But there are some studies out of Europe now that say that pyridium and NSAIDs are better for acute cystitis than actual antibiotic treatment. And in the WHO guidelines for antibiotic stewardship, we'll see where that plays out, right? Like instant gratification is it burns, it hurts, it pees, give me an antibiotic. So it's going to be a fine line for what we can do and how we push things forward. And hopefully as a group of urologists and gynecologists, we can work together to find some in between.
I agree. I would add that I use that regimen, the pyridium and NSAID regimen, for the patient who's going to be triggered. So if they're having, I had one patient who long distance relationships, he saw her boyfriend every weekend only, and they were treating her with Cipro every weekend. So I just switched her to Urabel and Motrin, and that worked. So anticipating a flare or a trigger, or going out to an Italian dinner and drinking wine and having tomato sauce all night, in addition to taking pre-leaf, I would say, hey, that's when you can use those things. Otherwise, pyridium is really, I use it just for, post-procedure patients who I did 4 urolifts this morning. They all got pyridium to help with that. But that has less to do with infections and more surgical pain.
Okay. Dr. Rechtschaffen, we'll keep the mic with you. The next question here is for you. Now you might have to help me through this question. I think it's got a number of parts to it. So what I'm reading here is, would you do catheterization for the NGS test? And then it asks, how do you feel comfortable it wasn't vagina if no cath? There's a question on insurance coverage. And then there's another part here that says your thoughts on negative UA, cath, and positive culture for E. coli.
Okay.
There's a few different things in there. You got that?
Yeah. Yeah. So catheterizing a patient is, has been classically the most sterile thing you can do. I think with something like NGS, the NGS's ability of really finding everything, it's not like culture. So it has the ability of finding every bacteria or organism in the urine. And we can identify which ones are typically not inside the bladder. They might be vaginal, or they might be just one of those, strep contaminants. And we're not going to pay attention to those. We also sometimes get results of lactobacillus in the NGS, and we know that many of those are healthy. So you're not going to treat that as well. But we're a patient who's having a lot of sort of 10,000 sort of, again, contaminant, possibly urine cultures. A cath that's when it's most appropriate, because you're getting a better sample. But because of the way the advanced diagnostics work, we can overcome that contaminant because we're able to identify the other bugs that are more pathogenic. I have gotten some vaginal stuff in these urine samples, and that's worth treating sometimes too. There's Gardnerella. I think it's worth treating because once you treat that, sometimes the patients do feel better. And what they're feeling is really a vaginal infection, not a urine infection. Negative UAs sometimes do come out positive. It depends how you do the UA. I think a patient who has a negative UA and no symptoms, you can leave them alone. But again, if they're miserable and having symptoms, that you should send a culture, and if they're symptomatic, I should say. In terms of insurance coverage, it is an issue, but it's changing. So many of the Medicare certainly, and then some of the private insurers are covering NGS testing. It is still an expensive technology. I think as we work towards sort of Uberizing the ability to access a test like this, whether or not your doctor does it, and the prices can be brought down, I think we'll be able to expand that, and that will have a bigger impact nationally on all these UTIs. If remember, the UTI cost to Medicare is, many billions of dollars a year. If we can start reducing that number with a slightly expensive test, but ultimately will result in a lot less cost to the healthcare system, it's probably worth it in the long run.
Okay, great. Thank you. Dr. Rice, the next question is for you.
Yep.
The question is around case number 2, which is the IC case. What was the cause of the cystoscopy findings that were interpreted as IC?
Oh yeah, so that's sort of a technical thing. So glomerulations basically are inflammation in the bladder. And the way that I tell people to think about this is, remember when you were a kid and you'd suck the cup to your face, and you'd take it off and you'd have a hickey on your face? Those are essentially broken blood vessels and glomerulations. So when you go into a bladder, and if you do hydrodistension and you have any kind of flares or any kind of lining issues, you can often make a bladder look like glomerulations as opposed to having true findings. So when I do cystoscopy, especially for true interstitial cystitis patients, there's things called Hunner's ulcers. And it just looks different. Like I usually describe it as like raw hamburger meat. It's a very distinct thing that you can kind of see. And there was a time and place, like as we talk about like next generation sequencing and stuff like that, right? So I agree. I think it's going to be kind of cool to see how it plays out. But right now we don't, for me, for that last question, I don't know, it wasn't vaginal flora, but if the patient got better with a dose of Flagyl, you treated their symptoms and you helped them, right? So just like it was with IC, it used to be that anybody who had IC or UTIs was treated with hydrodistension because they thought that that was helping the lining or the gags within the bladder sort of readjust themselves. So medicine is still very much an art, right? Like there are things that we learn, and the more people that listen, more particularly to women, just because women have a lot more recurrent UTIs, but the more you can listen to what patients have to tell you, the more you're kind of learning how to manage this, because my textbook is not always right. So just because I'm used to treating 100,000 more for a true bacterial UTI, there is more there, and we're going to learn more, and we're going to know how to take care of these patients better. So for that patient in particular, I think it was a product of, 10 years ago, thinking and processes about what IC was. And back then, I always joke with people, right? Like when I graduated residency, I was one of 11%, right? Nobody looked like me, right? And people like me have UTIs. So I always am like, was your urologist, older or, and it changes. And as women are more vocal and we have men who support us and are willing to listen to women, then we're getting more information.
That's great. Thank you, Dr. Rice. The next question is for Dr. Rechtschaffen. The question here, actually two people asked this and we've combined it together. It's around elimination diet. So the audience here is asking, could you please clarify the elimination diet in more detail? How specifically is this done? And how do you counsel these patients?
What was the last part? I'm sorry.
And how do you counsel for
Okay.
elimination diet?
So I try to send them to a dietitian who I work with. It doesn't work in my practice, but who I trust and I know it works well. Again, the food that we're eating is a lot of stuff in it. And at least you're eating sort of whole, raw vegetables all the time, which is not a way to live for all people. It's hard because the preservatives and what have you will react to the dyes, will react the amount of salt in these things that we don't know about. Certainly anything fast food can react, because I believe it's my sense that it's not an allergy to food. It's a sensitivity to some food. So you're not going to have anaphylaxis like to a peanut. But if you're having an inflammatory response to something in your body that you're sensitive to, because when Dr. Rice did mention biopsies, which I stopped doing after the first 50 patients all had mast cells, but it's an allergic reaction. It's mast cells and histamine is what you see in some of these IC patients. So obviously there's some sort of sensitivity to certain food products, chemicals. So it helps when you get rid of the sort of packaged foods, the fast foods, what have you. Beyond that, acidic foods, again, all their coffee, I tell them to stop drinking coffee and they want to, shiv me, but it does help. And they think tea is healthy and iced tea is great, but tea is more irritating to the bladder lining than coffee. So I talk about drinking more water. If they're young and like to go drinking, I said, have a glass of water between each drink. This way you'll feel a little better in the morning. So anything but water and probably milk is going to cause irritation. In terms of foods themselves, the citrus fruits, the tomatoes, spicy foods. There is a website that the Elmeron people put out, orthoelmeron.com. They do have a nice list of some foods that you might not notice, but I try to get them to a dietitian ultimately. And the motivated patients will do their own research and they will find the foods and they'll realize what they're doing that's exacerbating their disease. And when they are able to get rid of them, they actually feel a lot better.
Faraz, just tag teaming on that too. So I think for elimination diets, the UTIVA website and the app that I did, the UTI tracker app that we work with, that helps you sort of track and eliminate things too. Because I usually do a 3-day trial. As someone who has had chronic UTIs, I can't do that. I used to like to drink. I'm too old now, but I did. There was just no way I could do an elimination diet. So if you do 3 days of nothing, kind of veggies, whatever, and then add in something for 3 days, if that doesn't bother you, you're fairly good to go. Pick a different thing for 3 days, but you've got to kind of eat that same thing for 3 days to really find what your triggers are. And in my personal experience, the triggers can be crazy. Like I have one lady that it's watermelon, probably because of the high water content or sugar. I don't know, but she's not crazy. And the thing is that people were telling her that she was crazy because she couldn't find her triggers. So the more you can track and the more you can keep a diary, the better off you're going to find this. And dietitians are great if you have them because they're going to help you do all kinds of things for gluten and crazy other bowel stuff that I don't get into. But what I usually just tell people is get a good app or a good notebook and do 3 days without it in your system, 3 days with it in your system. And if it doesn't bother you in those 3 days, you're probably good to do what you need to do. But I agree, water and all that stuff too.
One great motivator is they don't want to be on these drugs long term. I mean, short term, none of them are great, but short term, they're probably okay and they'll work. but you read about Almiron, where they get hair loss and the macular degeneration long-term. And I wonder about amitriptyline, nortriptyline with dementia. Sometimes the allergy pills like hydroxyzine or Claritin, Zyrtec might be okay, but again, you don't want to be anything long-term if you don't have to be. So if I tell them, look, we'll put you on meds, we'll do a hydroextension, we'll do something short-term now, but while we're working on you, getting you a little bit more, human feeling, work on your diet, keep a diary, like Dr. Rice mentioned. If you went out last night to dinner and you feel terrible today, well, write down what you had. And that will be the best way to be long-term off of these meds that can be scary long-term.
No, thanks to you both. And simple things like, diet tracking, hydration, so important. And the feedback we get is, patients who are suffering from here are motivated to track. They just need to be counseled and guided towards that. So thanks for both of your answers there. I know it's about 9:03. We promised to 9:03 p.m. We're over the hour, but we have great discussion going on. We still have some questions here. So if our speakers are good, can we just continue on for another 5 to 7 minutes?
Okay, no problem.
Thanks, Dr. Rice. So we'll take at least 2 more questions here from the audience. The next one's over here for you, Dana, Dr. Rice, but feel free to jump in, Dr. Rechtschaffen, too. How do you dose ibuprofen for cystitis?
Yeah, so it's sort of a weight-based thing for me and time. So I usually find that 200 to 400 milligrams every 8 hours is more than enough. You don't want to go over 800 Q8, so you don't want to overdose the patient. I don't find for chronic pain type things that you need to be much over 400 milligrams every 8 hours. Kidney stones, different ballgame. Go for the 800.
Okay. The next question, I'll have it open. This will be our last question. So the next question, we'll have it open for both of you. Is what is the longest duration you can use prophylaxis antibiotics for UTI? And second part to this, please clarify how you use fosfomycin.
So I'll start. I use fosfomycin more than I used to. I think the NGS has really helped guide that. Again, it's a 3-gram dose. I usually take it once. It lasts a week, but it can be expensive if it's not covered. But certainly for people who've been on the typical, Augmentin, Ceftin, Bactrim, and even Cipro, not better. I think fosfomycin is useful in using that. And in terms of how long, I really resist keeping people on long-term antibiotics. I think in 20 years, I have these two patients who are on long-term antibiotics because it just seems to work for them. But I really try to avoid that.
It depends on how you look at it. So my answer is semi-similar, a little bit different too. So fosfomycin for me is fantastic, but you don't want to blow it out. So just like all the other antibiotics that we were talking about before, like long-term Cipro and things like that, you want to make sure that you're not overusing it. One thing I like about fosfomycin is that a lot of times hospitals will have it for fairly cheap. And I wish they would standardize care in the ER that you get 1 dose of fosfomycin until your urine culture grew back, because lots of times a one-time dose for acute cystitis is all you need. And it also would help take resistance out of the question. I do use fosfomycin often for multi-drug resistant patients. You can do 3 doses every 48 hours as a treatment dose. But often if it's an uncomplicated cystitis, you don't need that. So 1 dose would be more than enough until you wait for a culture. I was going to say something else. Oh, long-term antibiotics. So if you look at the PD world, right? So if you guys know me or you've read my app or anything like that, I had vesical ureteral reflux stage 5 surgically corrected. And my daughter also had vesical ureteral reflux, which is part of the reason how I got to doing these, being involved with apps and writing chapters and stuff like that. And the thing is, in the PD world, you keep kids on low-dose prophylactic antibiotics until they outgrow their vesical ureteral reflux or they're toilet trained. So we have kids on long-term antibiotics for a long period of time. Obviously, in the adult world, we really don't want to do that as much. And in your sort of healthy walkie-talkie 20 to 60-year-olds, or pick your average age, you're fine. But if you see a lot of chronic or sick patients, or a lot of my bladder cancer patients who are terminal, then yeah, I do keep prophylactic antibiotics as an option, but I have a really good discussion with them about why they are not clearing their bladder of these infections and their anatomical complications. So those are a different world. So again, those are things that you always want to make sure that you work with a urologist on, because they're not just straightforward UTI patients. They're complicated anatomical people who can't risk urosepsis repeatedly.
Thank you. Thank you, Dr. Rice. I think with this, we will wrap up our question and answer period. Dr. Rechtschaffen, did you have any other last final thoughts? I'll actually give both of you.
Yeah, sure. I'm really excited about microbiomes. We don't know enough yet, but we are able to populate them. I think I'm not old enough to remember this, but I trained under people who are old enough to remember treating C. diff with fecal transplants. How do we repopulate someone's urinary tract to a healthier microbiome? I don't think we've put our hands around it yet. Probiotics are probably part of the answer, but I'm not sure it's the whole answer. So I'm excited about working on making people healthier with better bacteria rather than giving them antibiotics.
Yeah, I agree. Or letting your natural biomes overgrow and take over. So if you can support someone through their acute symptoms or their acute episodes, and then hopefully they can sort of overgrow their own bacteria that take away the symptoms, and then you're colonized, but not necessarily needing treatment.
Okay. Well, thank you. Thank you, Dr. Rechtschaffen. Thank you, Dr. Dana Rice. We have still lots of questions coming in, but we will close it off here. We have promised some of the questions that have come in to see if we can send them to you later on. And if you have a chance, you can answer them, and then we can get them forwarded to some of our attendees.